Sherine, one of the reasons we invited you was to provide the perspective of the generics industry, but of course, as I learned more about last night, you've also been very much involved in research, and it might, in fact, be more accurate to ask you to speak from the perspective of somebody who runs a company based in an emerging economy, in a middle-income country. What struck you about what you heard earlier today?
What Felix said about the human rights, the intellectual property, and the big pharmas, and the dialogue which has been going on for years and years. So I think the slide that Bernard had put, which started having partners between DNDi, and I think they changed their name to DMPI, Drugs for Neglected People Initiative, not Neglected Disease, as HCV, as you say, has 71 million patients, not little amount like other sleeping sickness or others. So this, having the partnership of the government of Malaysia, where Dr. Noor Hisham showed the passion, the will to participate in R&D, and also going down to South America with a generic company that is ready to participate and to also work, and a company in Egypt, which is Pharco, that made the generic, and had 4 pre-qualifications from WHO for the API factory, for the finished dosage factory. For the drug itself, the dossier of sofosbuvir is 12,095 pages, and also the bioequivalence center. Coming to Presidio, which is an American company, research company, because when the sofosbuvir was rejected as a patent in Egypt, this was because of the delay after the scientific publication, which happened early, and the application of the patent by the company. So by the law of the WIPO, you're not getting the patent because the delay in application. So this gave us the window to interact. But this by itself wouldn't help. Why? Because when we started, the kilogram of sofosbuvir was for $1 million. So how can we help it? How did the prices go down? Did it go down on its own? No. We worked hard to do it. And I learned this from Gary Hamel in 1995 when he made Competing for the Future. And he said, who will create the rules of the game of the future? You or your competitors? So we started making a non-infringing process for making the raw material in new polymorph shape. We got some Italian experts. And we built an API plant, and we bought the first kilogram for $1 million. We produced the first 10 kilograms for $1,050,000. Then we produced 100 kilograms for $1 million. Then we produced a ton for $1 million. So we became 1 per 1,000 competitive, with one very important aspect, which was the political will of the president of Egypt. So when we started, we wanted to make a snowballing technique. How can we start making a strike to let this happen? So when we bought the pack for bioequivalence of sofosbuvir for $33,605 and 2 cents, we gave it to the Egyptian government for 5 cents. We gave them 150,000 packs for 5 cents. But what happened during this? Fortunately, the numbers which we saw today about Egypt, 1.8 million, this was till 2017. As I'm sitting now, it's 4 million. And screening of over 60 million of the population. So it's going to elimination before 2020. Thank you.
Sherine, let me turn to you. You have many, many other products that you are investing in beyond HCV. What are the lessons?
I think there are 2 things here. First, as we were talking about, is cancer oncology. How can we go for anti-cancer drugs? Because with the oncology products, it's terribly also expensive, and started vaccines and stem cell things. It's $300,000 for 1 injection or something like that. So I think the coalition which has started with DNDi, Malaysian government, Medicines Patent Pool, and so on, we should invest in this a lot. Also, another thing, when we started the screening process in Egypt, we started as an NGO with 8 mobile clinics from Germany and 4 million kits for testing. And by the way, the diagnostic prices in Egypt are very good. We have the Abbott pre-qualified rapid test for 57 cents, which I think is not much. And the PCR, it's less than $6, which I think also is not much. It's affordable now. So going back to the system, when we offered to the political authorities this screening campaign, and we made the 60-something thousand screening, it was not only for hepatitis C, but also for diabetes, hypertension, obesity, and many people were discovered with hypertension. They didn't know. They just take an aspirin when they have a headache. And after finishing this, Ministry of Health started screening for breast cancer for young ladies. Girls with 22 years old discovered they have breast cancer. They couldn't think or imagine that they have it. So discovering it earlier is better. So beyond Hep C, we used the screening campaign not only in discovering this, but also to make a map, a medical map for Egypt, which governorates has certain diseases and why. And also this helps in making the new health insurance system, because now you have data. If you have a database, you can measure and you can manage. But if you have nothing, you can do nothing. So I think with oncology, this could be something great for human help, because many multinationals are working on it. Okay, let's have a coalition, public-private partnership that can spend on this, can find a solution, and can make it with the NDI and Medicines Patent Pool affordable to all the countries. Thank you.
Thank you very much. My question is to...
And please introduce yourself briefly
Okay,
first.
my name is Kwame Pepra. I work at the WHO. I'm a consultant at the AMR division. My question is to Sherine. Throughout the discussions this morning, political will has really come up as one of the key strategies to make people sit up. What were the motivating factors in Egypt that really drove your company to get involved in this project? What sort of incentives did the government provide to your company to really make sure that you are successful? Because this is an issue that is not on the table of most low-middle-income country governments. And so I think the Egypt example should really serve as a nice tool to, advocate.
If I could take the moderator's prerogative to just piggyback momentarily on your question. We hear from many countries now, wealthier countries, middle-income countries, low-income countries, a growing interest in production of medicine, sometimes called local or national production, whether privately or publicly owned. What difference would it have made if you had just decided to import from India, for example, which is what we see with HIV? Why is it that local production or Egyptian production was the path that you took? What difference did it make for the national program? I'm going to hold, just while you think about that just for a second. I think we had one other hand up. Yes, please. Oh, no. Okay, then back to you.
Okay, I think the price could have been now $60,000, not $41. Why? The chicken or the egg? Who will start first? First, my father-in-law, he passed away from hepatitis C after blood donation with an injury. So luckily, I met Raymond Shirazi, the Raymond Shirazi, in 2012. And he was born in Alexandria, my town city, and we went to the same schools. And he said, okay, why don't you make medicine for Egypt and you don't make profit out of it? I said, okay, how can I do this? He said, start with making this. So the political will, what did it give me? It gave me the plan of the government to cure 1 million patients. With this, I jumped into economies of scale, where I could buy a company for R&D, I could build a company for API, could get the experts to make the new polymorph and make it happen. So starting from the real political will, and after we finished all waiting lists and we started ourselves as a company to make screening for millions of people and giving it also to the political presence of President Sisi. He said, okay, we will make the 100 million checks. And by the way, the media played a very important thing. We started ourselves making songs in the TV to show people what's the problem with HCV and to make lectures on auto-infection. How can a father and a son, they both have 2 razors in their bathroom, but both of them, they use the same towel. How to let them not have this? How to educate patients and people? So media was very important also to make people move and go for the 100 million checks. Also, they made 3,500 facilities. So for myself, I made the checkup at my building. I found a clinic downstairs. In 3 minutes, you can do it. Plus, the government put something enforcing, said, if you want to get driver's license, to get your ID, to get anything, you have to get your 100 million checks first. So by the law, you can enforce people to go, not tell them just see whether you have HCV or not. Thank you.
Sherine, can I turn to you?
Yes, Egypt is a cost-aware country. And I don't know if you know that our prices since 1986 till 2016, for 30 years, we cannot raise the price of a pharmaceutical generic. Yet, the price of the dollar was 0.8 in 1986, and then it was 8 pounds in 2016. So I'm not talking about the API prices raising, but just currency rates is multiplied by 10. Electricity multiplied by 10. Salaries multiplied by 70. Yet, the prices was fixed. So this fixation and squeezing made us more cost aware. So, for example, Pharco, we sell 700 million pharmaceutical packs for less than 300 million Swiss francs. So that's the private, it's not the tenders. So we're talking about less than half euro or half a Swiss franc per pack in the private sector. So we're not afraid of Mozambique, don't worry. I mean, we could be competitive anywhere in the world because of this squeezing of the government. The government made this only 2 things. In renting apartments, the prices are fixed since 50 years, and in having medicine. In the apartments, it made a big catastrophe because nobody is renovation or making things, so the apartments are falling down. And at the same time, nobody built new apartments, so people are squeezed 20 in an apartment. So it made another problem that now apartments are for millions of pounds. But for pharmaceutical, we are still in Egypt self-sustained. We produce 93% of our needs. What we import is maybe insulin, some oncology products, and so on. And we will start a new factory for biosimilars next year, and also for oncology with technology transfer from a Swiss company.
And this relates to the second question, of course. The second question, where I think there's many people in the room interested in the issue of AMR, where I would argue there's increasing consensus that the current innovation system is not working. Plenty of evidence to back that up, but of course lots of debate on what might we need to change. So let me turn to the panelists and ask them to comment on this question. Is the current innovation system working? Is it meeting public needs? If it's not, what is it that needs to change based on the hepatitis C experience, based on what you've heard today, and of course your own backgrounds and expertise? So perhaps I'll start with FIFA and ask you to also use this opportunity to offer any other closing remarks you'd like to do before we wrap up.
Thanks, Suri. So, of course, from an NGO's perspective, I'm going to say that the innovation system isn't working. Hep C is a great example because the price that was offered to Malaysia was $36,000 for a cure at the time of the compulsory license. And Malaysian household income is $1,300 a month. So you can see sort of how that's clearly an unfair price and won't lead to access. Pharmasats tax filings showed that they predicted that it would cost 188 million to bring sofosbuvir to the stage of final product. Gilead made 19.2 billion in the second year of its marketing, of sofosbuvir's marketing. And therefore, it was calculated that they would recoup the R&D cost in 4.35 days. And if you count the cost of them acquiring Pharmacet, it would take slightly, I can't remember the exact one, but slightly over a year to recoup the R&D cost. And today, many people still don't have access to HCV drugs, although the price reductions have obviously resulted in that improving. But we see this problem also with delaminid and bedaquiline, right? There's still a lot of access problems that exists, and of course Sutezolid, which is sort of hanging in the margins and not coming to the final stage because it's just not profitable to bring it to the final stage and bring it to market. So what do? Are we going to turn to the DNDIs of the world every time poor people need a cure? It's not feasible. Something needs to be fixed, and transparency is a step in the right direction. But of course, we need to seriously think about delinkage. And I know this word has been convoluted by different parties, but we really need to think about some kind of fund. For example, what the union's talking about, the I forgot what they call it, the price fund. I can't remember, but that's one of the things that we need to think about in terms of bringing these medicines and antibiotics to market.
Thank you. Sherine?
If I can conclude what I think, I'll have 26, I'm not going to say bullets, it's shots because we are in pharma, with the alphabets. So A, for affordability makes access. B, believe in the cause. C, create the rules of the game. 4, D, direction and political will is the clue. E, the ecosystem formation. F, funding till the snowball rolls. G, government support. H, harmony between the team members. I, infection control. J, join the right people together, like the NDI, other governments. K, knowledge transfer. L, logistics and economies of scale. M, media and education. N, NGOs involvement. O, organic growth will go naturally. P, pre-qualification to show quality. Q, quality, safe, effective, affordable medicine. R, R&D. S, strategic alliances. T, tour and cure, health tourism. U, United Nations umbrella. We need you to carry on, not just putting strategies and doing just the figuring the thing. Get involved, touch the base. Then we go to V, velocity and speed. If we have to cure by 2030 70 million, we cured 7 million in 7 years, 4 million of which was done in Egypt. So we have to cure at least 5-6 million a year. So we have to act and do something. W, will. If there is a will, there is a way. Y, yields analysis and data management. Z, zigzag, don't stop. And you will ask me, where is the X? It's the Xmas. It's Merry Christmas for everybody. And it's expatriates in the rest of the world. We can join all their centers for innovation. Thank you very much.
Record time for 26 bullet points. Thank you very much.